Good morning, everybody. For those that joined, I think we've got about 100 people who logged in. So thank you for all who joined us this morning. I'm Brian Hurley. I'm one of the co-project investigators on a TRDRP-funded project integrating smoking cessation services into community clinics. I'm joined here by Dr. Hinkman, who's the program officer for TRDRP, and by Norma Matumbe, who's a community engagement specialist with the project. I'll ask Dr. Hinkman and Norma to introduce themselves in a moment, but just so we all know, there are no disclosures of commercial support for today's activity, and here's the objectives for the day. We also have an agenda with 2 breaks. So we have a break planned at 10:10, and we have an additional break planned at noon for lunch. And tobacco use is a leading cause of preventable death worldwide. Cigarette smoke is a major risk factor for cardiovascular disease, and the prevalence of smoking among people below the poverty level is over 30%. So we think of tobacco use and tobacco use disorder as a health disparity. There's just under 1 million adults in LA County that still smoke. 1 of every 7 deaths is caused by cigarette smoking, and cigarette smoking and tobacco use products cost more than $4 billion per year in direct and indirect costs. So with that, Dr. Hinkman, thank you so much for joining us this morning as part of our Community Smoking Cessation Dissemination Day. Did you want to introduce yourself and say hello to the group we've been able to assemble here this morning?
Sure. Thank you, Dr. Hurley, and good morning. Welcome, everyone. Very pleased to be able to join you for the day of exciting programs around smoking cessation, and in particular for our populations who have Medi-Cal or lower income. And this is a community practice-based research implementation science award for TRDRP. This was an initiative we launched some years back. And really the focus is around how do we create sustainable systems change around smoking cessation and culturally sensitive tobacco treatments for people who are lower income, with the main emphasis on our Medi-Cal population. As folks are out there dealing with the public and helping them through the COVID-19 pandemic, I really do appreciate you joining these series of presentations and being part of this training. As some folks might be hearing on the ground, there are now people who are really rethinking their tobacco use given the impact of COVID on the lung environment. And I think that this is a key opportunity to really, at least inform, educate people so that hopefully they make decisions and choices that really help them have the best chance of preventing transmission or anything severe from that disease. So I know we won't be talking about COVID, but it does play a role. Just wanted to, let folks know that at TRDRP, we fund research in this area statewide, not just smoking cessation, but understanding the social determinants of tobacco use. And I'll end there and turn it over to Norma. Thank you.
Good morning, and welcome. Thank you all so much for joining us. I'm really excited. We've got over 120 people on already. We had about 240 who registered all over the state of California. We even had some folks from Philly and Chicago and San Diego and San Francisco area, UC Davis area. So thank you all. I'm excited about today. And I just like to help set the stage for us to be thinking about all the information that we'll receive today and what you will do with it when you leave. I'm the community engagement specialist for the Smoking Cessation Project that we'll be discussing today. I've spent most of my life and career building and helping to run nonprofit and healthcare organizations in Los Angeles and similar communities. By similar, I mean communities where health disparities abound. As you all know, smoking has been shown to have a direct causal or significantly exacerbating relationship to conditions such as cardiovascular disease, COPD, asthma, emphysema, and diabetes. Moreover, research shows that smoking can be detrimental to all systems of the body. I saved the cancers, specifically lung cancer, for last because I wanted to put 2 of my many faces on the list of statistics for the wretched health conditions and mortality that can be related directly to smoking. You see, my dad, who was always my biggest cheerleader and hero, died from lung cancer 12 years ago. In 6 months, I watched him go from a robust 185-pound, fun-loving grandpa to 95 pounds and too weak to stand on his own. He covered his mirror because he couldn't stand to see his own reflection. To emphasize the addictive quality of nicotine, he had 3 heart attacks before he quit smoking. By then, unbeknownst to us all, the damage had already occurred. Also, one of my dearest friends since 7th grade that I usually talk about during this segment waged a battle with lung cancer for nearly 6 years, and she died 3 weeks ago. Both of them smoked and had the hardest time quitting. My work with the Smoking Cessation Project as a community engagement specialist is personal. I want to help see that others do not have to watch family and friends fall ill, suffer, and die from smoking-related illnesses as I've done. The best plan is to prevent ever starting to smoke. The second best plan is to intervene as soon as possible. I believe that embedding smoking cessation services into medical and mental health clinics is moving Los Angeles County in the right direction. On a brighter note, within the last 3 days, I've learned that another dear friend made a commitment to change her smoking behavior and texted me that she had not had a cigarette for 20 hours. And that's a big deal when you're a heavy smoker. And another young man that I had the privilege of becoming acquainted with while working on this project also made a decision to stop vaping. This gives me hope that my work is not in vain. I'm proud to be a part of this team, and I look forward to better outcomes for patients struggling to rid themselves of this nasty habit. Again, welcome.
Thank you. Thank you so much, Dr. Hickman, and thank you so much, Norma. Norma, I very much appreciate, as part of our community symposium, it's easy to look at numbers and statistics and forget the human cost and the human toll. So I just want to express my gratitude. Thank you so much for, we can talk about the economic impacts and we can talk about the prevalence and we can talk about the numbers, but the reality is that these are people with lives, and this is real human suffering that is tangible, and these are years lost for people. And so I appreciate you reminding us of that. I think that's
sure. And I
important.
I think Dr. Friedman wanted to say something.
So for those that haven't met him, Dr. Friedman's the co-primary investigator of the Integrating Smoking Cessation Services into Community Clinics Project. Dr. Friedman, what would you like to share?
Good morning, everybody. Thank you
Hi.
for joining us today. I'm really proud to see that we have over 120 people already and listening, and hopefully we'll get some more later in the day. As Brian and Norma said, smoking cessation is a crucial issue for our society. I don't have a family member that passed away from it, but certainly I know people that have passed away, and I'm really touched by Norma's story about her father and her friend. So we're all into it for the same end game, is to end smoking, try to reduce it among people. In the meantime, and I thank Norval for giving us the funding and TRDP for the funding to do our important research. And it should be a great day. I'll touch base again with people at the end of the day, see how everybody liked it, but thanks everybody.
So Norma, are you good to walk us through some of the CEU mechanics and some of the housekeeping for the day?
I am, and Luce is my backup if I miss something. So I should share?
What I'll do is I'll go ahead and advance for you if that's okay.
Okay, cool. That's great. For those of you who are interested in getting continuing education hours, all the in-depth information was on the registration flyer, and these are the disciplines and licenses that this symposium will support for 4.5 hours of continuing education credit. And I think I'm supposed to read this verbatim. UCLA ISAP is approved by the California Association of Marriage and Family Therapists to sponsor continuing education for LMFTs, LCSWs, LPCCs, and/or LEPs. UCLA ISAP maintains responsibility for this program, course, and its content. Course meets the qualifications of 4.5 hours of continuing education credit for LMFTs, LCSWs, LPCCs, and LEPs as required by the California Board of Behavioral Health Sciences. UCLA is also an approved provider of continuing education for RADTs, KDACs, and all these letters that you see on your screen before you. CE credit will be awarded at the conclusion of the symposium. Partial credit will not be available for those who arrive late, leave early, or do not attend fully. And you'll be getting a code. I think that's coming up next. This is the code for you to use when you do your evaluations at the end, and there'll be more discussion about that at the end of the symposium, exactly how you get your CEUs and how to click on to do the GIPRA and any post evaluation questions that we have.
And Norma and Luz, Laura asked the question, if somebody's not getting CEU credit, is it possible to get a attendance certificate? Would you tell that person to just follow the same GIPRA process, or is there a separate process for people that aren't doing the CE credits?
No, right at the end of the symposium, a link will show on the screen, and you can click on that link. That's the GIPRA. Everyone needs to do the GIPRA if you want to have a certificate. And even if you don't want a certificate, we ask that you do the GIPRA, because that's the information that goes back to the folks that fund ISAP to provide these CEs for everyone.
So everyone gets to do the GIPRA, regardless of whether you want a training certificate or CE credit. And certainly if you want a training certificate, the way you do it is by following the same CE process will then get you an attendance certificate.
Right, but all you have to do is the GIPRA. You don't have to do the ones after that.
Cool. All you need is the GIPRA. Thank you.
Right.
All right. And you want to talk about the GIPRA?
Oh, we're going to do that at the end because it's a lot to remember.
All right. We'll do that at the end.
Yeah.
Sounds good.
And this lecture will be available. It's being recorded and it will be on this website, and we'll make this information available to you. If you can't take a screenshot right now, we'll pop this up at the end again.
And then Norma, the next slide is discussing your experience. And I'm wondering, should we skip that slide and go right into, or is there more you wanted to add?
No, this is good. We can go ahead. You can
okay.
Finish. Mm-hmm.
All right.
Okay.
So should we go to an overview of the project?
All righty then.
All right. So thanks to Dr. Hickman for joining us this morning. Your leadership as our project officer has meant a lot to us, and particularly during the coronavirus pandemic, and with all the changes that we're faced with making. Thank you so much for keeping our project going and functional, and so we just want to say with much gratitude. And thanks, of course, to Norma for being, in many ways, the conscience of our project. You know, making sure that we're this project is really a community project, and so thank you for making sure that we always keep the community in mind. So thank you to both, and of course, thank you to Dr. Friedman for being the inspiration, the person that started this entire process to begin with. So thank you, Dr. Friedman. So with that, I'm going to talk about an overview of our project. And this is a project that in our grant application we called integrating smoking cessation services into community clinics. But that's not what we tell clients or patients, right? What we tell patients is to kick ash, right? That's a sort of brand name for our project. And so our project was organized with 2 of the 3 counties' health departments, but really involving all 3. So our project involves the Department of Health Services, which is the county department that manages the physical health part of the county. The county operated primary care clinics and hospitals. There's a Department of Mental Health that operates the county community mental health infrastructure. And our partners at the County Department of Public Health, particularly in tobacco prevention and control, are our county partners who've been very helpful at making sure that the services that were integrated into the county-operated physical health services and mental health services are coordinated with the county-wide coalition around smoking cessation. And so just a quick word from the County of Los Angeles Department of Public Health is the department's tobacco control and prevention program aims to lower tobacco-related death, disease, and disability. and through changing the social norms of communities to create a social and legal climate where tobacco use is less desirable, less acceptable, and less accessible. And so laquits.com is the County Department of Public Health Tobacco Prevention and Control run website. And they've our partners at the County Department of Public Health have been really critical for us to, again, resonate with our countywide partners and coalitions. Our County Department of Health Services and our Department of Mental Health really has evolving capacities in slightly different directions. Our County Department of Health Services is now integrating behavioral health clinicians into primary care, and that's new. Within the past 2 years, we've seen, our clinics have no substance use disorder counselors, very few social workers, and those social workers really allocated to specific programs, to now having substance use disorder counselors, social workers, caseworkers, community health workers, staffing a whole variety of service lines related to behavioral health. So we had an opportunity to make sure that tobacco use disorder treatment was front and center on the agenda for our behavioral health teams in our Department of Health Services. And so now for the past, the staffing has been increasing over the past few years, but it really was 2.5 years ago that we developed a set of training materials and really began promoting smoking cessation as a core part of behavioral health and primary care. And our Department of Mental Health has a broadening focus. The Department of Mental Health is funded to do specialty mental health treatment. Specialty mental health treatment includes a number of diagnoses. One of the diagnoses that's not included is tobacco use disorder, right? So the Department of Mental Health has said, there's a whole number of not strictly mental health Medi-Cal billable activities that are important for the health and well-being of people with mental illness, particularly including tobacco use disorder. And so we got agreement from both departments to integrate smoking cessation services into primary care because they were increasing their primary care capacity, and into mental health because they were ensuring that a broad set of services was delivered as part of comprehensive mental health. And so we had an opportunity to do a kick-ass program in both departments, right? Both Department of Health Services, Department of Mental Health, with support from the third department in the County Department of Public Health. So in the Department of Health Services, it's shy of 20% of DHS patients are identified to be smokers, which is roughly comparable with the known sort of prevalence of tobacco use disorder among Medi-Cal beneficiaries. And it is higher than the statewide average, which we think of as, well, anywhere between 10 and 13%, kind of depending on the population that you look at. And then of the smokers, only a fifth or so actually, as baseline when we started this project, were documented to have received an intervention like referral to the California Smokers Helpline, like prescription of a medication for smoking cessation, or documentation of smoking counseling being done at the clinic. And then at DMH, smoking rates among people experiencing mental illness is higher than smoking rates outside of that group. And so we know that the people that receive mental health services smoke more, and that was true in the DMH data. So just shy of 30% of DMH clients were identified to be smokers, and counseling was offered to less than 20%, and medications were rarely prescribed. It was less than 2% of people with tobacco use disorder were prescribed any medications for smoking cessation in the Department of Mental Health. Now, I've mentioned this already, but I would be remiss. Our plan has and continues to be to connect people to the statewide Smokers Helpline. The statewide Smokers Helpline, 1-800-NO-BUTS, or nobuts.org is their website, is a statewide resource for people in all socioeconomic demographics. It offers telephone counseling, offers linkage to a whole number of services. There's self-help materials that are posted there. I mean, there's a whole bevy of resources. So we're not looking to recreate that. But one of the things that we thought is, yes, there is this statewide resource, but the statewide resource is not operated by the clinic. And could we help expand and amplify the benefit of the statewide resource if we had prescribing clinicians, that is, doctors, psychiatrists, doctors, including psychiatrists, nurse practitioners, physician assistants, other providers, prescribe medications where patients are already getting their medical care? And what if people were getting smoking cessation counseling where they were already getting counseling in the clinic? So to look at what the effect is of integrating these services into the usual and ordinary county-run processes in the mental health and health services clinics. So we put together a project embedding smoking cessation smoking cessation programs in LA County clinics. And we said we want to set up a program where the county itself delivers smoking cessation medicines and counseling. Now, the grant that we got from TRDRP is not the sort of grant that would pay for all of these services, right? We weren't funded to pay for the cost of all these medications and hire a bunch of counselors and run a randomized controlled trial. So that's not exactly how we organized it. We said we'll use the funding to support training and support some of the implementation science interventions. And then we'll pay coordinators to assess the effect of those interventions. So it's really an implementation trial, not a RCT. We know these medications work. We know counseling is effective. So we're not necessarily testing the effect of the counseling. We're testing the effect of implementing the evidence-based strategies into what the county is already doing. So that's how we set up our project. We got approved through the Department of Public Health IRB, and it's based on an already validated integrating smoking cessation model that's been employed at the Veterans Administration. So we started with 6 clinics operated by the Department of Health Services and 6 clinics operated by the Department of Mental Health in order to see what was the effect of our intervention compared to treatment as usual. We randomized 1 clinic, 1 out of every 6 clinics, to the treatment as usual arm. Now, since we've started, we actually have now had an opportunity to expand beyond the 6 initial clinics in the Department of Health Services. So we're now looking at expanding to 12 to 13 different sites in the Department of Health Services, and are still now in the process of increasing the number of sites that we're recruiting, and we're planning to keep a 1:6 randomization ratio. So 1 out of every 6 clinics that we onboard will remain treated as usual, and then we'll offer the intervention, which is technical assistance for running a smoking cessation counseling program, and additional training on prescribing medications for tobacco use disorder as part of our intervention arm. All right. So these were the initial sites, so MLK Jr., Roybal, Harbor UCLA's Carson Clinic, Harbor UCLA's Lomita Clinic, the Humphrey Comprehensive Health Center, and the Mid-Valley Comprehensive Health Center were the initial 6 sites. And we are in the process of adding additional sites, again, with a 1:6 sort of randomization ratio. And then for our community mental health centers, our Arcadia Mental Health Center, East San Gabriel Valley, Harbor UCLA, South Bay, West Central, and West Valley. And it's now been well over a year since we really have gotten these sites up and running. And we're looking at what is the effect of the county delivered, right? Not grant funded, but really county delivered smoking cessation program on smoking behavior in DMH clients and DHS patients. And so we're evaluating this by recruiting people with tobacco use disorder who are existing patients or clients of the programs that we've evaluated for baseline surveys and follow-up surveys. We're asking people about their smoking behavior. We're also, pre-COVID, we're doing carbon monoxide breath testing and urine cotinine testing. Now, the risks of in-person assessment of exhaled carbon monoxide are now, initially when we started, we thought, no big deal, right? Somebody blows into a machine. And all of a sudden, that becomes much more risky in the context of the coronavirus pandemic. And so we're no longer collecting exhaled carbon monoxide values, nor are we collecting urine samples to test for cotinine, but we are still assessing smoking behavior over time. And then, as the pandemic progresses, our hope is before the conclusion of our project, we will be able to, go back to do some assessment, some biological verification of smoking behavior. We also are doing surveys of the clinic staff themselves to see what is the effect of these integrating these services on the perceived appropriateness and efficacy of smoking cessation treatment. We're doing periodic medical record review to look at attendance during sessions and receipt of medications. And we're doing periodic group therapy supervision to assess the quality of the counseling that's being provided. In order to sign up as a DHS patient or client, you have to be 18 years or older. You have to currently be a patient at DHS or client of DMH. You have to be smoking at least 3 tobacco cigarettes a day on average, and you have to want to reduce or eliminate your tobacco product use. You don't have to want to quit necessarily, because it's still relevant if our intervention causes people to reduce their tobacco usage, but our primary endpoint really is abstinence. And we think for enrollment, we'll take anybody at any stage of change, but we're hoping that over the course of the year that people participate in our programs, that they do achieve abstinence. So that's our primary outpoint. And then the exclusion criteria is if you don't meet any of the criteria above. So if you don't use tobacco products, if you don't want to change your tobacco product use, if you're not currently a patient, if you're not over the age of 18, you're not you're excluded from meeting the criteria to enroll. And there's up to $50 a year worth of incentives, and somebody can, once they start their enrollment process as a study participant, you're enrolled for a year. So I mentioned self-reported smoking behavior. We are assessing tobacco use disorder and withdrawal symptoms, quality of life measures, and we do a baseline measure and then a follow-up at months 3, 6, and 12. And we were doing carbon monoxide and urinary cotinine measures and plan to resume that if possible once the COVID-19 restrictions are phased out. And then again, our primary outpoint really was smoking abstinence, and in an ideal state verified by carbon monoxide and cotinine testing when we can get it. And then we're also looking at how does this affect, the stability of smoking abstinence, right? Who abstains briefly versus who abstains over time, any effect on depressive anxiety symptoms, effect on quality of life. And we've got a whole other secondary analysis over where there are certain treatment strategies or approaches, or, are there clinics that seem to generate more abstinence than other clinics. Those are all comparisons that we can do, again, as we increase enrollment. So if you're attending as a participant and you're like, I really want to refer a patient of mine to the study, Luz Rodriguez and Brianna Lopez are our study coordinators, and their email addresses and phone numbers are posted up here. And I do want to express a lot of gratitude to TRDRP, who's funded our project, our Friends Research Institute, who's our county kind of fiscal partner, right? The entity that's administering our grant, and of course the Department of Public Health Tobacco Control and Prevention Program. And so this is the email. It is my email address, Brian Hurley. I work as the Director of Addiction Medicine for the county, in addition to my role as the co-PI. Norma Matumbe, who we've met as our community engagement specialist. Tasha Dixon, who is our behavioral health consultant, who's helping us with the technical assistance for programs, and then Luz and Brianna, who are our project coordinators. And so before we go to the poll questions, I do want to say, Luz or Norma, anything that I missed here in the overview of the project, anything that we should add for participants that may not, I want to disabuse anybody of anything that I misstated. So anything that we should add at this point?
I don't think so. I don't see anything.
Okay. So poll question 1, Norma, I had a poll question that I put in here, but I wanted to, but the poll question that I had was related to the smoking cessation medications. So is there another poll question we should use here, or should I defer this until I start talking more about smoking cessation? Oh, here we go. It's already in.
Yeah, I don't think we did this one yet either.
No, we haven't done this one yet. Did you want me to say? Did you want me to save this poll until later?
Yes.
All right. So we'll go ahead and do the smoking cessation medication talk, and then the poll question will hopefully be more relevant. Does that sound okay?
Mm-hmm. Yeah.
All right. All right. So I'm not going to spend a lot of time. So I'm going to now transition away from talking about the project to talking about treating tobacco use disorder, but I do want a chance to just leave a little bit of space. Does anybody have any questions about anything we've covered so far?
We had one question asking, does DHS and DMH serve foreigners?
Yes. Yes, DMH and DHS serves people who are not citizens of the United States.
Thank you.
Yep. People who are not citizens of the United States are oftentimes ineligible for Medi-Cal. but the county safety net will see people who are not Medi-Cal eligible.
Okay.
But you have to be a resident of LA County.
Yes, you have to be a resident of LA County, but you don't have to be a citizen of the United States.
Okay, one other question. Does this program include LGBTQ competency in the trainings for expanded tobacco cessation programming?
So our Kick-Ash program does not include an LGBT specific component, but I'd be curious, Shannon, if there's sort of LGBT competency that you think should be a part of our Kick-Ash trainings, we'd welcome the input, because we're continuing to conduct the trainings. I think there's standing training 6 times a year plus monthly supervision. So we welcome any input into enhancing our trainings to be more responsive to LGBT communities. But our curriculum at this point, while talking about engaging all populations, it's a more sort of general culturally responsive curriculum that's not does not include and it's oriented towards safety net populations. So predominantly communities of color from under-resourced communities is like most of the group that we're working with. But you know, that's certainly intersectional with sexual and gender diversity. That's certainly intersectional with linguistic diversity. That's certainly intersectional with a whole number of other ways that we could be culturally responsive. And so if you have ideas for how we can enhance the LGBT competency in our trainings, we'd welcome your input. And I'll go ahead and say that I answered that live.
I was going to add, Brian, that we also had a smoking cessation symposium in February 2020, more geared toward providers. We had an excellent session on targeting LGBT.
We did. Yeah.
That's available, both the slides and the PowerPoint, if anybody wants.
We did, yeah. It's definitely been a part of our dissemination, whether it's our provider-focused trainings or community-focused trainings. Yeah, we've had a number of LGBT discussions as part of the not the curriculum, but the dissemination we put together. And then by resident, do you mean they have to have a U.S. resident card? Lourdes, so you have to either have an LA County address or have identified an LA County location where you're unsheltered. So you have to, by resident of LA County, it does not mean you have to have a U.S. resident card. It just has to mean that you can identify a location in LA County where you're residing. So whether that's a physical address or whether that's a location where you're unsheltered. So that's the, yep. So answer live. Okay, cool. So for this next part of the talk, I'm going to talk about medications for smoking cessation. And typically this is the part of the talk where we start with smoking is bad for you, right? We sort of go into all the ways that smoking is bad for you. And I'm not going to spend a lot of time talking about prevalence or trying to convince you that smoking is bad for you. I actually think there's people way more eloquent than I have that present way better data than I have that I can immediately access that can make that point. So this is the one slide I have. It turns out smoking is bad for you. It's the #1 cause of preventable death. And if you look at the leading annual deaths attributable to tobacco use disorder, it's lung cancer, heart disease, COPD, or other pulmonary diseases, a variety of other diagnoses. And if you think about the #1 killers in the United States, it's heart disease and strokes, right? It's cardiovascular disease. And so one of the reasons I think that smoking oftentimes is not identified, let me take a step back. So in the country, we've faced a number of public health threats. So right now, the one that's front and center, the one that's capturing all the attention is coronavirus, justifiably so, right? It's a pandemic. Pandemics come and then they go, right? So the pandemic will have an end. It's unclear exactly what the time frame is, and that's sort of the uncertainty. But the trend of the coronavirus infection comes and it goes. We've had an opioid epidemic now for a very long time. And in fact, one of the reasons that the opioid epidemic is so trackable is that on the death certificates, it says something like opioid overdose, which is the leading cause of death among people with opioid use disorder. One of the challenges with tobacco use disorder is, tobacco use disorder is not what's on the death certificate, right? Like somebody will smoke tobacco for decades. And it's the cumulative effect of all that smoking that causes heart disease. So their cause of death is heart attack, stroke, congestive heart failure, right? It's the cardiac effects of decades of smoking. The death script says lung cancer, other types of cancers. And so that's the challenge with the tobacco epidemic, is that it doesn't oftentimes get put front and center as the cause of death. It's the proximal, it's the reason, it's the driver of the heart disease, the stroke, the lung cancer, the COPD, or other lung illnesses. But oftentimes, these diseases are sort of conceptualized as, the problem is the COPD, the problem is not the tobacco use. I would say, well, no, actually, really since Edward Bernays in the turn of the century, right, we saw the big rise of tobacco use in the United States. That's the cause of a lot of this death and disability. So this is I'll get off the soapbox. Smoking is bad for you. I'm going to talk about how the approaches of how you can treat people with tobacco use disorder with medications and behavioral strategies. But this is the one slide that kind of goes over a fair amount of the epidemiology and why. This is the case as to why would we treat tobacco use disorder. Okay. So I'm going to talk about medications for tobacco use disorder, but before I do, I just wanted to posit a framework. The treatment of tobacco use disorder has three arms. There's medications, and there's counseling, and there's support, and they're all important options. And these options exist for other areas of medicine too, like diabetes, for example, is treated with medications and diet and exercise. And like major depressive disorder or depression is treated with meds and counseling and support. So the treatments for tobacco use disorder, the framework for it is not actually terribly different than the framework that we would offer people with other types of behavioral medicine conditions. And so for smoking cessation pharmacotherapy, I'm going to talk about just one of those arms, but I don't want the fact that I'm talking about just one of those arms to preclude, I don't think the meds are the everything to smoking cessation, right? Meds plus counseling plus support are the three arms of treatment for smoking cessation. And I'm going to right now start off our symposium talking about just the meds, but just to make it clear, but meds plus counseling support is what we think of as the full menu of treatments for tobacco use disorder. And I don't have any conflicts of interest to disclose. So I'm not being paid by any drug companies that are going to try to sell anybody here or anything. So this is the smoking cycle. I got this off quitplan.com. And it's, you smoke, nicotine goes to your brain quickly, so you feel good. But when the nicotine levels drop, you have a craving for another cigarette and you think, I want to smoke, right? So, and you do this enough and you develop a tobacco use disorder. And so this is a similar schematic of the intoxication cycle. And it's really in the craving and in the use circles that these medications seem to really be effective. And so if you have, let's say you have a friend or a family member and you're interested in helping them smoke less, one of the things that we remind providers is to ask and then advise and then assess and then arrange. And people sometimes think of smoking as a habit. In fact, Norma even mentioned, this nasty habit of smoking. I would say smoking is a habit, but it's also medical. So one of the things about smoking is that smoking changes the way that your body functions. And in fact, it changes the way that your body processes medications. When you smoke cigarettes, the smoke itself, it has something called polycyclic aromatic hydrocarbons. And that's the cancer-producing inflammatory parts of the smoke. And that causes your liver to metabolize medications more quickly. And so one of the challenges to successful treatment for let's say people with mental illness, and you try to support somebody with meds and counseling support for whatever's going on with their mental illness. If they take meds, the meds are going to have a lower blood level because that person smoked compared to somebody that's not smoking. And if you want a list, there's actually the New South Wales government in Australia has, I think, one of the more comprehensive lists of all of the different medications that are affected by tobacco use. And it's not actually nicotine itself. Nicotine is the addictive part of tobacco, but it's actually the smoking itself that seems to cause the liver to metabolize medications more quickly. Even though tobacco use disorder, I would say, is a medical condition, it oftentimes rarely ends up in the medical chart. And this is a survey or a set of surveys that were looking at the diagnosis of tobacco use disorder in mental health settings and the rate of treatment of tobacco use disorder in mental health settings. And it turns out mental health settings, which seems to see the highest number of people with tobacco use disorder, are doing the least in terms of diagnosing and treating it and connecting people to things like the California Smokers Helpline. And so if anybody does work in a mental health setting, you know, there's no excuse to not be aware of the California Smokers Helpline. It is a substantial statewide resource that's helpful to a lot of people. So I do want to talk for just a moment about tobacco use disorder medications. So there are 3 molecules that seem to work, 3 different specific medications that seem to be effective to help people that want to change their smoking behavior. So one is nicotine replacement therapy. Now, nicotine replacement therapy comes in a couple different formats, actually 5 different formats, but it all is based on the principle of using nicotine to keep somebody out of nicotine withdrawal. It helps reduce or eliminate cravings. There's another medication. It's an oral medication. It's a pill that you swallow. It's called varenicline. It goes by the trade name Chantix. And it's a pill you take twice a day. And it also blocks your nicotine receptors, but blocks nicotine from binding to them, but helps provide a little bit of nicotine activation. So it helps keep you out of withdrawal, but also makes smoking much less rewarding. And then there's a medication called Bupropion. It goes by the trade name Zyban. And it has metabolites or parts of the medication that metabolize in the body. Parts of those medication affect the way your nicotine receptors work. So all of these medications work on your nicotine receptors. And to be clear, we've got 3 formats: nicotine replacement therapy, bupropion, and varenicline. I'm going to pause here for questions. Norma, did you want to address the infographic on the public health impact of tobacco use?
I know where it came from, and we've been using it now for about a year and a half, so it's at least that old. But Nancy, I can email you the website. This is from CDC website, where you can maybe get more updated, but you know, the data lags behind a lot of times. But it's, if anything, it's gotten worse. Just know that it's not better yet.
Thank you so much. And then Phyllis, you said, is there a national hotline? So there's smokefree.gov, which is a national national resource. Smokefree.gov, though, links you to the statewide helpline. So if you went to smokefree.gov from California, it would link you to the California Smokers Helpline. But each state operates their own, or my knowledge is, to my knowledge, each state has their own smoking cessation strategy. And if you were to say leave the state of California and go to another state, smokefree.gov is how you could find your way to your state's resource. So I'll go ahead and answer that live. And then Adelaida, how long do people have to be on medications? Not a day longer than necessary, but actually that depends on patient to patient. It sort of depends on, so in general, with meds plus counseling plus support, the more counseling and support you do, the less duration, the less long you need to be on meds. For people who have a more severe form of tobacco use disorder and are doing less counseling and support, oftentimes people need to be on medications for longer. But I'm going to talk specifically about the meds, so we can talk a little bit more about duration when we talk about the specific medication strategies. If I'm mispronouncing, I'm sorry, but Sialan said, what about 2 of the 3 arms? I would say any one of the arm, you know, meds or counseling or support could be effective, right? Each, you know, there's people that only do meds and don't do any counseling and support, and they reduce or even eliminate their tobacco product usage. There's people who do counseling alone with no meds, that can be effective. So yes, 2 of the 3 arms can absolutely be effective. You don't need all 3. All 3 are on the menu. It's sort of like, you know, I recommend all 3, but if it's not feasible for somebody to get some support to do any counseling or to take any medications, any positive change can be effective. And the way that I think about it is it sort of depends on your tobacco use disorder. There's some people with a less severe form of tobacco use disorder. All they need is some counseling strategies, and they're good. There's people with a more severe form of tobacco use disorder, and oftentimes you really do need all three. So it sort of depends on somebody's individual smoking behavior, but the medications can be effective even without counseling and support. And counseling can be effective even if somebody doesn't take medications. Okay. How do I know if the medications will help my cravings? I just quit vaping, but I still smoke cigarettes. Gideon, while nothing is ever guaranteed in life, we know that these medications strongly reduce cravings. So it sounds like you quit vaping, congratulations on that, but you still smoke cigarettes. When you smoke cigarettes, the thing that causes cravings is the nicotine. So if you can use a nicotine replacement therapy or use something like varenicline, which is Chantix, or Bupropion, which is Zyban, to help reduce cravings, it will help reduce cravings. I think the key question is, will it reduce cravings enough for you to actually quit? And that's where meds plus counseling support come in. Like some people, oftentimes many people need 2 forms of medications, plus counseling, plus support, depending on what's going on with your tobacco use disorder in order to put together a strategy. And the other thing we know about tobacco use disorder is that it takes time. Like you try quitting, but then oftentimes you get tripped up somewhere, right? You try quitting, but then you're in a situation with people, places, and things, right? It was a big trigger to relapse. So you're in a situation where you use again. So next time you do a plan, right? Use counseling to plan ahead to either avoid those situations or to engage a strategy when you're in those situations. That might mean, you pop a nicotine replacement therapy gum or lozenge, or nasal spray or inhaler, right? To help curb any cravings in those moments or those situations. So now Gideon, I'm not giving you particularly medical advice, but I'd say in general, we know these medications do help reduce cravings, and you would work with whoever is, what's the right word? You would work with whoever's prescribing you the medications, or the California Smokers Helpline, let's say, in order to be able to find a strategy that's going to work. Is there different dosages recommended for smokers versus smokers, tobacco users versus e-users? I have a whole set of slides on a medication strategy. So Shannon, if we don't get to that towards the end, I will let you know. And then, third was Bupropion. Thank you, Jocelyn. And then, is it common for providers to use the nicotine coating to determine proper treatment based on each individual's nicotine metabolic rate? Shannon, no, we're generally not using nicotine metabolic rates. We're just estimating it based on nicotine consumption. So we do an assessment of how much are you smoking. And by smoking, I mean vaping, chewing, right? You try to come up with some estimate of how much nicotine somebody's taking in. So the rule of thumb is 1 milligram per cigarette, or 20 milligrams per pod, which is the kind of the usual strength of the vaping pods. And there are vaping pods of different strengths. So if somebody's using a vaping pod of a different strength, you would want to factor that in. And then you dose nicotine replacement therapy to match or even exceed the amount of nicotine that somebody is taking in through a tobacco product with nicotine replacement therapy. For Bupropion or varenicline, those are fixed doses. So you don't, if you're going to use Chantix, which is varenicline, or Bupropion, which is Zyban, you generally put somebody on the standard dose. There's not really a dose adjustment, but you do adjust the nicotine replacement therapy to match or even exceed the amount of, slightly exceed the amount of nicotine that somebody is taking in, but you don't do it by metabolic, like you don't then do a urinary coating and then do it from there. You just sort of say, okay, this is how much nicotine you're taking in. This is how much nicotine therapy I would recommend. And I think I recommended that. And all right, cool. So thank you for your wonderful questions. So how do these work? Well, this is the technical language, but nicotine replacement therapy simply exists by replacing nicotine, right? Like if you're, what's the right word? If you find yourself in nicotine withdrawal, it just replaces, it eliminates that withdrawal. With varenicline, it blocks nicotine from binding, and for bupropion, it also changes the way that the receptor binds to nicotine. So there's actually a report that came out on smoking cessation. It's the updated report of the Surgeon General, and there's a whole list of smoking cessation medications. So there's 5 forms of nicotine replacement therapy. There's patches, gums, lozenges, nasal sprays, and inhalers. And then separately, there's bupropion, which is Zyban, and there's varenicline, which is Chantix. So these are the meds that we have. And how do you use them? Well, I'm prescribing you a patch to quit smoking. Please wear it over your mouth. You don't actually put smoking cessation patches on people's mouths. You put it on people's skin, ideally in a hairless area where the nicotine that's in the patch absorbs into the body through the skin. And the most effective strategy we think is combined nicotine replacement therapy, the patch plus the gum or lozenge or inhaler or nasal spray. You can also use varenicline and combine that with the gum or lozenge or nasal spray or inhaler. And there's actually some studies of people that combine varenicline plus the patch. Although that is a little counterintuitive, usually I recommend either using the patch or varenicline, and then on top of that, offering my patients gums, lozenges, nasal sprays, or inhalers as needed if they have any breakthrough cravings. And then bupropion on its own doesn't appear to be as effective as combined nicotine replacement therapy or varenicline, but I do add bupropion if somebody has any depression, because bupropion is an antidepressant. It's also a medication that can help lessen weight gain that can sometimes happen when people stop smoking. So I mentioned these are what we know about the clinical trials, but what's the most important thing to know to help somebody stop smoking? I'm sometimes asked, what's the best medication for smoking cessation? It's patient preference, right? Like if somebody's like, look, I don't want to take any nicotine replacement therapy. I just want to take, Chantix. Okay, right? Like I do think of combined Chantix plus nicotine replacement therapy or patches plus other forms of nicotine replacement therapy to be, all things being equal, the recommended first line. But if somebody doesn't want to use any patches or gums or lozenges and they just want to take pills, we can offer them varenicline, and we can also offer them bupropion. So patient preference, what's the best med? It's the one the patient takes, right? Patient preference is front and center. And then things like, am I familiar with these medications? Do I understand how they work? There's a lot of providers I work with that just prescribe the patch. They've never prescribed varenicline. They never prescribe bupropion for smoking cessation. They don't prescribe gums or lozenges. They're just familiar with the patch. I think that's one of the reasons that I do the work that I do to promote the treatment of tobacco use disorder in the public setting, is so people know how to use these medications effectively, but it oftentimes has a pretty big impact. And then there are medications that don't agree with everybody, right? There's some patients that don't do well with varenicline, which is Chantix. There's patients that don't do well with nicotine, right? So somebody's past experience is also an important characteristic. So the patches comes in 7s, 14s, 21s, and 28s. That's the strength. You put the patch on in the morning and make sure to take it off before you go to sleep. If you wear it overnight, it can cause nightmares. Because you take it off overnight, people will wake up in nicotine withdrawal. So I recommend to have gums or lozenges nearby so that when you wake up, you're able to take something that can put you out of nicotine withdrawal quickly. And so we recommend combining the patch with the gum or lozenge that can really help somebody reduce their tobacco product usage. So the gums comes in 2s and 4s. So I sort of say there's the weaker and the stronger versions. The way that these work is that they absorb through your cheek. So sometimes people take the gum and they just chew it. And they're like, okay, I'm chewing the gum. That does not work. Chewing the gum does not seem to help people with tobacco use disorder. It's chewing the gum until you taste a peppery taste, then push it against your cheek. It's the pushing it against your cheek that is how this works. It's the nicotine goes through the cheek and enters your body. When it's not wet or when the gum is sort of spent, then you chew it again to refresh the nicotine and then push it against your cheek. This is called the chew and park method. And if you just sit there and chew, the nicotine gum, or I had a patient like pop a lozenge and chew the lozenge really quick and swallow it, all that nicotine goes to waste. It goes into your into your saliva and down your stomach, and your stomach breaks it down without absorbing it. So, the best way to use the gum or lozenge is by activating it, by swirling it around your mouth or chewing it, and then pushing it against your cheek, and that's how it works. You do get some immediate relief with the gum or lozenge, but it's less than inhaled. There are inhalers and nasal sprays. The gums and lozenges you can buy over the counter. They're also covered by Medi-Cal by prescription. Depending on your health plan, different health plans have slightly different benefits, but they're generally they are covered by Medi-Cal. And the inhalers and nasal sprays are also covered. Typically, they're prescription only, and they're typically available, but either with a TAR, which is a prior authorization. I do understand that Medi-Cal policy is shifting, and that we're in the process of making inhalers and nasal sprays more available. In the county system where I work, the inhalers and nasal sprays are not on our own county formulary. So the county formulary has patches, gums, and lozenges, but we can only get inhalers or nasal sprays through what's called a non-formulary request. Bupropion goes by the trade name Zyban. It is also the same thing as Wellbutrin, which is an antidepressant. So Zyban was the trade name for smoking cessation. Wellbutrin is the trade name for depression. But it's the exact same thing. It's Bupropion. So most people now know of Bupropion as Wellbutrin. It's also an antidepressant. It improves the probability of quit success and helps reduce weight gain. But Bupropion, although is not an uncommon medication, has a number of side effects. It can cause seizures in people that have epilepsy. It's not recommended in people who have bipolar disorder and who don't have an adequate mood stabilizer prescribed to them. So it can also cause insomnia, it can cause jitteriness, it can cause dry mouth. So it's a common medication, but it's not necessarily a totally benign medication. Every medication has side effects. Bupropion is no different. The usual strategy is you get somebody up to 300 milligrams a day. So sometimes you start at a low dose and titrate up, but 300 milligrams a day is what we recommend as the standard dose of Bupropion. Initially, if you go back to the initial studies where Bupropion was discussed, you use a shorter acting version and you take it twice a day. So 150 milligrams of the Bupropion sustained release is the usual sort of in the textbook. If you actually, I'll go back to the slide real quick, is in sort of the standard chart, the usual recommended strategy. We now think that the once a day Bupropion XL, which was not approved for smoking cessation, works just as well. In my own experience with my patients, once a day medications are better adhered to. So I prescribe the longer acting once a day Bupropion extended release, the XL, at 300 milligrams a day rather than asking patients to take a medication twice a day. And then, and you can safely combine it with nicotine replacement therapy. There are people that take Bupropion for years, right? And so one question was about duration. And there's people that take Bupropion for many decades of their lives, and it has no known sort of long-term adverse effects in people that tolerate it well. And then varenicline, which is Chantix. This is a medication that slightly activates your nicotine receptors, but blocks anything else from binding to them. That also means that if you should sort of go up slowly on varenicline, but then you should taper off varenicline. It's not something you should abruptly stop or start, because you can actually go into nicotine withdrawal and get cravings if you just stop taking it. The usual duration of varenicline is between 12 and 24 weeks. So that's 3 and 6 months. Although there are people who sometimes need year-long or even longer treatments for varenicline, which can get tricky because insurance companies oftentimes don't pay for more than 3 months at a time. But it's a twice-a-day medication. So you start at 0.5 milligram once a day for a few days, then go to 0.5 milligram twice a day, and the usual maintenance is 1 milligram twice a day, and you continue it as long as the patient's finding benefit. Typically, the medication helps you curb your nicotine cravings, makes cigarettes feel less rewarding, and then you learn how to become a non-smoker, right? You learn how to drink coffee without smoking and how to tolerate stress without smoking. You learn how to have meals without smoking and take breaks without smoking and how to socialize with people without smoking. And that's how we think these medications really work, is by relieving your physiologic nicotine withdrawal for long enough for you to develop the skills as a non-smoker. Now, I'm always asked, so I'll just throw it out now. I'm asked about varenicline and suicidality and varenicline and heart disease. So there's actually a number of pretty good trials. I'll start with varenicline and heart disease. There were a number of trials in December of 2012 that suggested that the varenicline was associated with heart attacks and strokes. When we actually went back, the FDA went back through the data and said, actually, the events are really uncommon among people treated with varenicline or not treated with varenicline. Actually, there was no statistically significant difference. And so the health benefits of quitting smoking are immediate and substantial. The health risks associated with varenicline for heart disease are sort of small and inconclusive. And the recommendation from the FDA, and I would say sort of consensus in the field, is the benefits of not smoking using varenicline outweigh any potential cardiovascular risks, which are, I would say, inconclusive related to varenicline. And then I'm also asked, like, does varenicline make you crazy, right? Do you get suicidal? Does it cause an exacerbation of psychiatric symptoms? So I will say varenicline sometimes makes psychiatric symptoms worse in some people. So in people who are prone to suicidal thoughts, those are people with severe depression or certain types of personality disorders, and people with sort of uncontrolled psychosis or bipolar disorder, there are the risks of varenicline making your psychiatric side effects worse. However, the serious side effects on mood, behavior, and thinking is not very high. So it's a possible risk, but it's not a very common risk. And in trials, although most people that had these side effects did not have serious consequences such as suicide behavior or psychiatric hospitalizations. So again, although varenicline can be associated with worsening mood, a worsening psychosis, suicidal thinking, that happens rarely. When it happens, it tends to not be serious or severe. And the results of a couple trials, one thing is one trial in particular, the Eagles trial, confirmed that the benefits of stopping smoking do outweigh the risks of treatment with varenicline. So I treat people with varenicline. I treat people with schizophrenia with varenicline, bipolar disorder with varenicline, severe depression with varenicline. And if it makes people worse, I stop the varenicline, right? But I don't withhold varenicline from people just because they have a history of mental illness. And then there are medications that can be offered that aren't these three FDA-approved medications. So clonidine and nortriptyline are thought to have some efficacy. These are both generic medicines, so I'm not trying to sell you anything. And I'm not going to discuss them in any detail other than to say there are medications that aren't these three that I've talked about so far that seem to be helpful. So what about medication treatment during pregnancy? Well, I mentioned there's meds plus counseling plus support, and the conventional wisdom is during pregnancy, you don't want to expose a developing fetus to medications that aren't absolutely necessary. And so counseling without medications is usually where we start, but not every pregnant patient is able to quit smoking with counseling alone. And so the conventional wisdom is I'd rather have somebody in counseling and getting nicotine replacement therapy rather than getting counseling and continuing to smoke. Because if you smoke, you're getting this nicotine anyway, the same nicotine you'd be getting from nicotine replacement therapy, plus all the polycyclic aromatic hydrocarbons that cause things like intrauterine growth restriction and threaten the pregnancy. So if I'm going to prescribe a medication to a pregnant patient, it's going to be nicotine replacement therapy. The safety of bupropion and varenicline is not well established during pregnancy. And you can breastfeed while taking nicotine replacement therapy. Again, I'd much rather have a patient who's pregnant who has tobacco use disorder treat with nicotine replacement therapy compared to continuing to smoke. We do know that bupropion is in the breast milk of women, and depending on the situation, we're not typically using bupropion for patients who are pregnant. What about patients with mental illness? Well, most patients experiencing mental illness need higher doses, longer duration of treatment, and really do benefit from the combination of meds plus counseling plus support. I have had patients on a year or even longer of varenicline, which is Chantix, which is well over the sort of package recommended duration. And there's no necessary harm to treating with that long, but I'm always looking for opportunities to help support somebody learn some additional skills and get some support, such that they may not necessarily need to be on varenicline, for their entire lives. Patients with bipolar disorder should really only receive bupropion if they're a mood stabilizer, and you can use all three in people with schizophrenia or schizoaffective disorder. What about quitting in rehab? So, I recommend quitting smoking as part of an alcohol or drug addiction treatment program. The way that funding is organized, both nationally and in Sacramento, is we carve out addiction treatment from the rest of healthcare. And so our drug Medi-Cal funded programs are not funded by drug Medi-Cal to treat tobacco use disorder, right? Tobacco use disorder, they would have to find other funding streams in order to be able to treat tobacco use disorder. But stopping smoking while you're quitting alcohol or methamphetamine or cannabis or, opioids or whatever other drug actually helps support recovery from all substances. And so I'll say, if you send somebody to drug addiction treatment, the chance that that person's going to quit is about 14%. But in addiction treatment, smoking is so prevalent, like 80% prevalence of tobacco use disorder in people who are in addiction treatment. We find that non-smokers, about 11% of non-smokers start smoking when they go to addiction treatment. So my own experience, and I say this as an addiction psychiatrist that works in addiction treatment, is it can be a scandal, right? You help people, you want to help people stop smoking, but because smoking is so common there and so sort of woven into the culture of addiction treatment, that you get 11% of people that came in as a non-smoker, maybe their alcohol use disorder is now treated or improved, but now they've developed a tobacco use disorder by virtue of being in treatment. And I will just say, smokers who stop smoking as part of addiction treatment really are more likely to be in remission from their primary substance use disorder. So here's a set of slides on the recommended medication strategy. These slides are going to be posted, and so you'll have access to this. But this is what I tell providers at the Department of Health Services: is if somebody's not smoking every day, give them a gum or lozenge that they can use instead of smoking, right? So if they're going out or they're in a situation where they're smoking, they can use a gum or lozenge. And then if you're smoking a quarter pack a day, which is technically 5 cigarettes or less, but in our slide we say up to 8 cigarettes a day, to use a 7 milligram patch plus the 2 milligram gum or lozenge, and then you can always add bupropion to the patch plus the gum or lozenge, or varenicline, which is Chantix, plus the 2 milligram gum or lozenge, plus bupropion if the patient's interested. And then as the amount of cigarettes somebody's smoking goes up, the strength of the patch goes up if the patient's using the patch, and the strength of the gum and the lozenges goes up. So that's the recommended medication strategy. Do I recommend vaping? I do not. E-cigarettes are not associated with more quitting among smokers. Nicotine replacement therapy is, but vaping, my own experience with vaping is that people that transition from using cigarettes to using vapes, they smoke less cigarettes, right? So you can cut down on your cigarette use using a vape, but then you're using a vape, right? And there's no evidence that vaping helps you use less vaping, right? So you can transition your addiction, let's say, from conventional smoke cigarettes to vapes, but then you have a vape use disorder. And vaping is not benign. We sort of think of, oh, well, vaping is not as bad for you. There's plenty of instances of lung injury, hospitalizations. The American Medical Association had a big statement about vaping. I mean, vaping has a number of health consequences. So somebody asked me about a national resource. Smokefree.gov is that national resource. There's 12-step groups around smoking cessation. Nicotine Anonymous is one such group. UCSF has a really deep bench of resources and information, including a lot of the information I presented here today comes from UCSF. And I don't recommend light cigarettes. They're just as dangerous. Smokeless tobacco, snus, or e-cigarettes. The key with quitting smoking really is persistence. It's you try to quit, and then you try to quit again, you try to quit again, and then each time be using meds plus counseling plus support to support a quit attempt, because we know that the medications, even without counseling and support, double the chances that you're going to be successful during any given quit attempt. And this is my email address if there's any questions. Why don't, Norma, we go ahead and put the first poll question, if we could, and then I'll go ahead and take some of these Q&As. So can somebody take the lozenge or gum before bed to avoid morning cravings? No. If you use the gum or the lozenge before bed, it's out of your system in the morning. So the solution to morning cravings is to have the gum or lozenge in the morning, because it only lasts in your system for a couple hours. So if you use it at night, it's not going to be in your system by the morning. So answer that. Is there a weaning regimen for stopping Chantix? Yes. So if you're on 1 milligram twice a day, generally then you go down to 0.5 milligram twice a day. And how long you taper that depends on how long you've been on Chantix. So if you've been on Chantix a month, usually you go down to 0.5 milligram twice a day for a few days, like 3 or 4 days, and then you go down to 0.5 milligram once a day for about a week, and then you come off. But if you've been on Chantix for several months, then you go down to 0.5 milligram twice a day for several weeks, and then 0.5 milligram a day. So you organize the taper to match the more or less the duration that you've been on Chantix. And then is the recording of this presentation will be available? Yes, it was one of the slides we covered initially, but yes, we're going to make this available. And who is entitled to provide nicotine replacement therapy? Doctors, nurse practitioners, physician assistants, and clinical pharmacists can all, and other advanced practice nurses can all prescribe nicotine replacement therapy. And RNs can do it under an order from any one of those providers. So the rule of thumb is doctors, nurses, doctors, nurse practitioners, other advanced practice nurses, physician assistants, clinical pharmacists, and anybody else with prescribing authority. But I think that's the short list. One other quick thing. So we're in the midst of a pandemic, and I don't have a ton of slides talking about the pandemic, but I'm just going to say, with the way that we're organizing our project, I mentioned counseling, and our counseling has historically been group counseling. The nice thing about group counseling is that the group members can learn from each other, and that one counselor can treat multiple patients at one time, right? So you both get peer learning, and you're able to amplify the time of an individual counselor. We're not really doing groups within the Department of Health Services. And the Department of Mental Health is largely, it's not exclusively cut out groups, but the groups are happening very rarely in the Department of Mental Health. And so we're now transitioning to do a lot of our counseling virtually. You can do telephone prescribing of these medications as well. And depending on the pharmacy, there are pharmacies that will do deliveries. In DHS, we're working with patients to help support people getting medications as they need them. Sometimes that's deliveries, sometimes that's couriers, sometimes patients come in, but we're supporting people with longer duration prescriptions to avoid people needing to come into the clinic or needing to break physical distancing in order to be able to get their medications. So I do want to highlight, although this presentation has not been adjusted for COVID, we are very much in the process of adjusting our usual and ordinary practices by doing telephone visits as opposed to in-person visits, supporting people by getting their medications, however they need it, and that oftentimes means longer duration prescriptions to avoid somebody needing to come back and forth to a pharmacy all the time. Kathy says, what about support? Does that mean case management? So case management is one type of support. I think of support as really broad. Support to me can mean, a church group. It can mean family. It can mean a friend group. It can mean there's a whole number of things. And we know that things like being unsheltered, having unstable housing, having unstable employment are all things that exacerbate tobacco use disorder. And case management has a huge impact on whether somebody is housed or has access to the services that helps them support their wellness such that they don't need to smoke. So the question is under, thanks. Which one of the following symptoms is most common in people who are in nicotine withdrawal? Many people said it's difficulty sleeping. It was 75%, which is the correct answer. So thank you. So who, in California, who and with what credentials can bill Medi-Cal for case management? Oh gosh. Kathy, I need to get back to you on that. Because I actually think it sort of depends on I believe it might be somebody with a professional licensure, but I don't know that it, I think that would include social work, LMTs, licensed nurses, right? Can all do case management. But I know a lot of the case management that happens in the county happens through our whole person care program, which is not a billable, it's not billable to Medi-Cal. It's sort of a separate arm of Medi-Cal that goes for wraparound services. And those are like community health worker focused programs that aren't billed in the traditional way. So if your question is who can do a fully billable service, it's typically licensed clinicians. But in LA, there's a whole number of other funding streams that aren't like strictly fee-for-service billable Medi-Cal that we're able to use to help support a lot of patients with support activities that would ordinarily be under the umbrella of case management. But I'll need to get back to you. If your question is specifically who can bill, I'll need to get back to you on that. Okay. Thank you so much for everyone's time and attention this morning. I'm at 1 minute over. I'm sorry about that. But at this point, I'm going to stop sharing my screen.